Greetings, I'm Dr. Sean Thornton. I'm a pathologist with Solnetics Pathology and Laboratories, and I work with the doctors in the Swedish Cancer Institute. I've been asked to talk to you about the pathology and biology of breast cancer and what roles a pathologist plays in your care. First, you may wonder what a pathologist is and does. Pathologists are doctors that work for their patients behind the scenes, often completely and anonymously to the patient. Unlike the exciting pathologists on the CSI TV shows, the usual pathologist spends her or his day quietly and carefully studying thin layers of human body tissue under the microscope, looking for anything unusual. Once we have gathered all of our data, we construct a document, the pathology report, that is sent to the patient's primary physician, who will then discuss the pathologist's findings with the patient. Next, let's discuss what breast cancer is. All cancers are genetic diseases. Breast cancer is no different. This means that the DNA which makes up the genes in the affected cells has been damaged, resulting in unusual or abnormal cell growth. Common genetic changes result in cells that grow or multiply faster than normal and cells that don't die when they should. Both of these situations result in growing groups of cells that are multiplying out of control. These abnormal cells may have the capacity to spread to other parts of the body via the blood or lymphatic systems. Typically, breast tumors are divided into two different types, depending on where the tumor is located. To understand the location of these tumors, let's first discuss some breast anatomy. The breast is composed of the ducts and lobules that make and transport milk to the nipple, and the connective tissue which surrounds and supports the ducts and lobules. One way to visualize the breast organization is to think of it as a bunch of grapes. The grapes are the location where the milk is made. To get the milk to the nipple, the grapes are then gently squeezed, forcing the milk into the ducts, here represented by the stems. The first type of tumor is called in situ carcinoma, or one that occurs within the lobules and ducts. In this photo, you see smaller rounded structures, which are the lobules, and the larger elongated structure, which is the duct. This is the way tissue looks under the microscope. In situ carcinoma can only spread within these interconnected structures, and importantly, cannot spread into the nearby breast tissue or spread to other parts of the body. In situ carcinoma is usually treated primarily with surgery. Radiation and hormone therapy may also be recommended after surgery. The second and more serious type of breast tumor is called infiltrating carcinoma. This occurs once the abnormal cells have suffered additional mutations or changes that give them the capacity to break out of the ducts and lobules and crawl into the surrounding breast tissue. This type of abnormal cell is what we typically think of as cancer. It now can spread within the breast, grow to form a lump, and has the ability to spread to other parts of the body, what doctors call metastasize. The treatment of infiltrating carcinoma varies depending on certain factors, including tumor size, the extent of local spread, lymph node involvement, and the existence of certain tumor features. To determine if the breast tumor is in situ carcinoma, infiltrating carcinoma, or both, a pathologist uses his or her microscope to examine the breast tissue taken at the time of biopsy. Beyond that, we also go on to describe the tumor based on other observations. For example, breast cancers usually come in one of two major histologic varieties, ductal or lobular, just as does the in situ type. These terms refer not only to the site of origin of the growth, but typically each has unique characteristics when viewed under the microscope. In this photograph, we see that the tumor cells are forming little ovals, or ducts cut in cross-section. So this is an infiltrating ductal carcinoma. In the next photo, we see the tumor cells are no longer making ducts, but instead are invading the supporting tissue in single file fashion. This is characteristic of lobular carcinoma. Distinguishing the difference between ductal and lobular carcinoma has some minor importance, as patients with lobular carcinomas are at slightly increased risk for having a concurrent cancer on the opposite side. Therefore, a breast MRI may be recommended for patients whose tumors show lobular differentiation to look for abnormalities in the opposite breast. Other microscopic characteristics are also determined, such as tumor cell size and the number of cells actively multiplying. These factors give an indication of how aggressive the tumor may be and are listed in the summary pathology report. The patient can and should ask her doctor to explain them and their significance. Typically, cancers are found when a patient or her doctor feels a lump, or an abnormal finding on a mammogram is identified. In this photograph, the rounded whitish structure is a cancer. Lesions like this are typically targeted for a small biopsy, which undergoes microscopic evaluation by your pathologist. Additional imaging studies may also be performed, such as an MRI or a PET scan. The information gathered from the pathology evaluation and the imaging studies is used to help design the most appropriate surgical approach. The patient is given all of the information about her disease, which can be overwhelming. Her doctor will take the time to explain all of the findings and answer all of her questions so that she can make the very best informed decision as how to treat her disease. At this point, the affected area is usually removed surgically. Sometimes patients will elect to have the entire breast removed, a procedure called a mastectomy. At the time of surgery, it is usual to sample the lymph nodes in the armpit on the side affected by the cancer. A technique called the sentinel lymph node procedure may be used. This procedure is designed to identify the single lymph node most likely to have metastatic cancer. The risk for the patient to suffer the complications from totally removing all of the lymph nodes is greatly reduced when removing only the sentinel lymph node. Your pathologist examines the sentinel lymph node during the surgery while the patient is still under anesthesia. If metastatic carcinoma is found microscopically during this examination, the remaining lymph nodes are removed by the surgeon. During surgery, if the pathologist does not find cancer in the sentinel lymph node, the remaining lymph nodes are left in place. This is a very important and sometimes stressful examination for your pathologist, but be assured she or he is diligently working to get the right answer for the patient. Once the surgery is completed, the breast tissue must undergo adequate preparation before the pathologist can evaluate it. These preparations include adequate fixation in formaldehyde, evaluation of the tumor size, selection of the portions to be reviewed under the microscope, and the cutting and staining of the slides containing the extremely thin layers of human tissue. These processes generally take 1 to 2 days. Once the glass slides arrive in the pathologist's office, the pathologist looks at the tissue under the microscope to determine the final tumor size, histologic subtype and grade, and to evaluate how close the cancer comes to the margins of surgical resection. The lymph nodes are also evaluated under the microscope. Next, all of the factors are compiled into a single overall description of the tumor, called the pathology report. This data is used to define what is called the cancer stage. The stage includes the following components: description of tumor size, if cancer has spread to the lymph nodes, and whether it has spread to other body parts if that information is known. Staging information is important because it is used to determine the best post-operative treatment and to give the patient an idea of how other patients with similar disease have fared in the past. Additional testing is usually performed on the tumor as well. These tests help us to determine if the tumor cells are expressing estrogen receptor, progesterone receptor, and whether a protein called HER2/neu is overexpressed. These determinations will impact the type of chemotherapy, if any, is needed. For example, if estrogen receptor is present on the tumor cells, an anti-estrogen drug, such as tamoxifen or an aromatase inhibitor, may be prescribed as part of the chemotherapeutic regimen. It is the pathologist that orders, evaluates, and scores these special tests. Many of the tumor-related findings we've discussed are fairly straightforward to determine, but can sometimes be misread. Therefore, it is recommended that when patients move their treatment to a new doctor, their previous pathology results be re-reviewed. This is called getting a second opinion. It is not a terribly costly procedure and can greatly aid in helping the oncologist gather all the information needed to make the best recommendations to the patient. Your pathologist works for you behind the scenes. Most patients never see or even know that a dedicated doctor is working hard on her behalf. Pathologists greatly enjoy helping patients in their journey dealing with breast disease. We are called the doctor's doctor, but I like to think of the pathologist as the patient's advocate. The next time you have a biopsy, know that a specially trained doctor, your pathologist, is working just for you. Thank you very much for listening to the Swedish Cancer Institute's podcast in the Breast Cancer Series, Pathology. For more information, please contact your personal physician.